So it's 8 a.m. and we'll go ahead and get started. I actually have the pleasure of introducing Dr. Christian Ramers, who I've known for quite a long time. And so I was asked to give his introduction. I didn't receive anything specifically from him, so I thought I'd just make up an introduction for him, which I think will be more fun anyway. But Dr. Christian Ramers attended medical school at UC San Diego and completed a combined residency training in internal medicine and pediatrics at Duke University. Then from there, he did a HIV, an infectious disease fellowship at the University of Washington, where he also earned an MPH degree focusing on global health. At that time, he worked with UW's ITEC program on HIV education projects in Tanzania, Mozambique, as well as Angola. While he was there, he worked with the Northwest AIDS Education Training Center on an HIV-focused telehealth program called the Northwest AETC ECHO, which was modeled after the successful ECHO program that you may be more familiar with at New Mexico. And so from there, he then came to San Diego, and I think that we at UCSD missed an opportunity to actually pick him up at UCSD because, in my opinion, I think he's one of our best clinician educators here in San Diego. And I've certainly had the pleasure of working with him as part of the Pacific AETC HIV Learning Network. And so he's been an absolute pleasure to work with. He also does some advocacy work with the American Academy of HIV Medicine. He's the head of the California and Hawaii chapter, and he corralled me into working with him as well too on that. So I've had many opportunities to work with him. Now he currently is heading Family Health Centers of San Diego, and I think has done an outstanding job with really turning around their entire program and really creating a powerhouse in HIV care, as well as hepatitis C, which he works in as well, and also with he's developed a MAT clinic there and has really served the underserved population. So it gives me great pleasure to introduce my friend and my colleague, Dr. Christian Ramers, who's going to talk today about COVID-19 in people with HIV, evidence of increased risk. So Christian, go ahead and take it away.
Thanks, Dan. That's way better than anything I could have written for you to say. So I really, really appreciate it. And it's really nice to see a lot of familiar names in the Zoom chat. I have to say, I don't know about you guys, but this has been quite a ride the last 9 months. I feel like every talk I give, I'm less and less prepared, and I'm picking out errors in my PowerPoint because this is actually my 12th talk of the week. But so please be gentle on your line of questioning. What I wanted to do today was really give just a quick epidemiologic overview and then share a couple of our data points from family health centers, because I think we have a really unique vantage point with this COVID-19 outbreak being so focused in the South Bay. Us and our colleagues at San Ysidro have really been seeing, I think, a different part of this pandemic than maybe some of you have. So I'll share some of those, and then we'll get into really a quick review of the literature of COVID-19 and HIV patients or people with HIV. And I don't want to pretend that this is comprehensive because, again, we've all been so darn busy, but I feel like I can give a good broad sweep of the literature as I know it in terms of how this disease is affecting our patients with HIV. And then finally, I wanted to, vaccine is on everybody's mind, so I thought I would do a little bit at the end in terms of just talking about the COVID-19 vaccines that have recently been approved. So let me go ahead and go forward here. There we go. Okay, those are my disclosures. So we're looking to cite some of the emerging literature on the specific biological impact of HIV on susceptibility to COVID-19. We'll talk about the impact of the pandemic on practical issues such as HIV and PrEP care in the United States. And then we'll look a little bit at the guidelines, and I inserted those other couple of things like I mentioned. So I didn't have time to register this completely with Marvin or Daniel, but maybe we could just use the chat for this polling question. This is a check all that apply. We're almost 9 months into the pandemic in San Diego since the first cases arrived in March of this year. And I wanted to see what the impact has been on you all as providers. The answers here are A, I've had patients die of COVID-19. B, I've been involved in the management of my patients with COVID-19. C, I have had to shift my practice towards telemedicine. D, I've been less busy during the pandemic. E, I've been more busy during the pandemic. F, I see my patients much less frequently. Or G, I am seeing more mental health symptoms in my patients. And of course, you can do multiple answers there. And we'll see what people say. Thank you, Terry, for jumping in. So we've got some votes for B, involved in the management of COVID-19, less busy. Wow, interesting. And C, F, and G. Lots more telemedicine. Every time I do a telemedicine talk, it's just amazing that nobody was really doing it before, and now we're getting there. Unfortunately, some are saying A. I've seen some patients die, and then a lot of G's, a lot of mental health symptoms as well. So I'll give you maybe a couple more minutes to vote there. Yes, and a lot of people actually not seeing their patients as frequently. So that's an interesting thing. Daniel and I just had a HIV Learning Network discussion yesterday about this, and I shared that I have patients that can't wait to get back in to see us because they're so isolated, and just wanting us as their social support really during the pandemic. So thank you for voting there. Let's see if I can move along. So I'm going to start just with some sort of wisdom, if I can, or some thoughts of what this has been like for me personally. You know, I'm out speaking to people a lot, and it's just been a fire hose like I've never seen before. Up on the top right is this PubMed Lit COVID, it's called, which has been tracking the COVID-related publications, and there's almost 80,000 that have happened. And if you see the axis there, the y-axis, there's about 2,000 publications per week that have been tracked here. And you all have experienced this with me, I'm sure, that the scientific method can be messy, and things like masking guidance that first people said don't wear masks, and that, you know, look at all the controversy that caused. Think about the hydroxychloroquine debacle. The battle goes on. I think the current battleground is actually with ivermectin. The Congress just had a hearing where they had a group of kind of fringe doctors really pushing for ivermectin to be included in guidelines without really evidence. And we really need to just stick to our guns. Don't trust the scientists, trust the science, and actually just use our methods for evidence-based. But at the same time, if we wait using our traditional scientific method and wait for full, you know, multiple randomized controlled trials for things, sometimes we're waiting a little bit too long. So it's been really hard to get that balance right in terms of when to jump on therapeutics and when to start using them. This debate rages on right now with monoclonals that we can have in a healthy way. But you know, in the midst of crisis, sometimes we have to make decisions based on limited evidence. Sometimes I feel like an emergency medicine doctor making decisions on limited evidence. On the bottom are just a couple of other thoughts that I think our patients and also the community is depending on us for support, companionship, ongoing care. We can't forget about all the things that people need outside of COVID. And then really reliable fact-based advice and information. And I just want to encourage all of you, when you're speaking to your families and your Facebook friends and your Twitter feeds, that everybody's looking to us for good advice. And there's just too much information out there. Most of it is bad. And people make decisions based on the information they have. So all of us can really play a role in that and just trying to keep up to speed on what's going on. I think our PPE has proven sound. You know, I've been very much exposed. I was working our tents on Monday to try to do our testing, and I saw 20 patients, and a third of them were COVID positive. There's a lot of exposure going on, and the PPE actually works if you use it right. I think our clinical care is improving. We heard from Jess Mandel at the clinical town hall that there's just, you know, great intensive care techniques that are helping to keep people alive. The therapeutics have been, I'd say, relatively disappointing. I really want an oral antiviral that I can prescribe to people as soon as they're diagnosed, and it's just really not looking like anything is in the pipeline except for this molnupiravir, which has been studied in ferrets that may be promising. And then of course, vaccines are here, and that's really what everyone is kind of talking about. So this is my obligatory Johns Hopkins slide, almost 70 million. I've been watching the countries kind of shuffle up and down, and we host a Latin American echo in Spanish on Mondays and Thursdays. And boy, the whole continent of South America has been hit so hard. And if I did the snapshot about a month ago, actually Colombia, Peru, Argentina, Mexico would have all been in the top 10, and they've actually been subsumed by Europe. France, UK, Italy, and Spain have just come raging back in terms of these infections that are happening there. But suffice to say, right below this list, when you get down below Argentina and Colombia, you get to Peru and Mexico, where there's just been a tremendous amount of suffering and death there. And of course, we all know the story in the US. I used to show this map and show how it evolved. It's really just on fire everywhere now. I think Vermont is the only place in the country, in addition to some of the outer territories like Saipan and Guam, that have really low-ish related infection rates, but really everywhere is kind of on fire now. I wanted to share from Family Health Centers what we're seeing. So early on in March, thank goodness we have a very responsive high complexity lab that was able to not only get our Abbott M2000 machine running at full capacity with overnight shifts, but also we purchased another one. So we've been able to run, close to 400 tests a day, which has been very nice to help serve our community. And we've just seen incredibly high positivity rates, and really, I think, demonstrating the definition of a health disparity, where if you followed the county positivity rates for a while there in October and early November, it was 2 to 3%. And we've been ticking along in those red bars, as you can see, above 10% almost the entire summer. In November, we overall had 18% positivity. And this last week, I get these reports automated to me every 8 hours. And the last 15 or so that I've calculated were above 25%, and most recently 29% positive rates. So really a different kind of epidemic when you look at our outward-facing public testing sites in the South Bay and in the central area of San Diego. Here's our testing dashboard. So the green bars here are the number of tests that we send per day. The purple and blue are just other diagnoses that people took their tests elsewhere, but the reds are positives. And if you go from just October all the way through November, I saw Chris Longhurst post that UCSD had a record of 100 positive cases across the entire UCSD system. Well, we've hit 96, so we're really right behind you. And you do the math here, 96 out of 337 tests, that's about a 28 or 29% positive rate. So that's just kind of the view of what we're seeing. And we've really wanted to make an effort of just trying to protect our ERs and trying to protect the hospitals from people just swarming in the ERs, and really have tried to train our providers to do really excellent telemedicine management of COVID-19 in as much as that's possible. And then, we're dipping our toe into other things really to try to keep people out of the hospital as well. I think the understanding of this disease pathophysiologically is best captured by this diagram. There's a slightly newer version of this that Daniel Griffin, an ID doc from New York, has been purporting as well. But this kind of captures it for me, that we have a viral response phase from the onset of illness, where of course the viral load is at its highest at the onset of illness and really declines precipitously after that, whether or not therapeutics are given. And I'm referring to the monoclonal studies there. But really within about 7 to 10 days, the virus is almost completely gone. And then really the people that get increasingly ill are those with a very aggressive and or dysregulated immune system response. Those factors, of course, are just being understood now. But in terms of therapeutics, just to briefly mention on the bottom, we have a few things, either with emergency use authorization or with approval, remdesivir, many strong opinions on that. I think I made this bar as sort of green in the middle, but white on the sides, because we think there's really a sweet spot where this actually works, and then plenty of patients where it doesn't really do much at all. Dexamethasone I make red on the beginning because I've already seen in many patients coming to me who seek care in Mexicali or Calexico or Tijuana, just getting dexamethasone thrown at them as outpatients. And I'm really concerned about that because, as we know, early steroids can actually blunt the innate immune response and really cause some harm, as was alluded to in the big Solidarity trial. Not a significant result, but definitely a trend towards increased mortality when you use dexamethasone too early. However, in other infectious diseases, we use steroids and antimicrobials at the same time, thinking about pneumocystis pneumonia or TB meningitis or even cellulitis. In some cases, people can use antibiotics and steroids, and that actually works just fine. But unopposed steroids, I think, is really a worrisome thing to do. Oxygen is there, convalescent plasma is there as well, though there's really, I think, some emerging evidence that convalescent plasma may not be that great. There's some auto antibodies that might be related to thrombotic events that have been shown to be present in convalescent plasma. So we might be giving some of those to people and maybe causing some problems. And then the evidence was really tough to sort out whether the effect was really good. And then baricitinib, probably a really expensive version of a steroid like dexamethasone. And from the outpatient perspective, there's been this giant hole in terms of what we can offer our patients, other than companionship and reassurance and prevention messages. There's been really nothing there. It's been quite disappointing. Lots about hydroxychloroquine, which didn't turn out to work. Lots of talk about ivermectin now, and then vitamin D and zinc and other things here. But there are two agents that have been offered EUA approval. Bamlanivimab from Eli Lilly and casirivimab and imdevimab from the Regeneron group. It's worth noting that bamlanivimab was just the first of a combination. I think there's another one that Eli Lilly is trying to develop. It's called LY-CoV-016, and ultimately they want to have a combination product as well. But this has been actually the only sort of movement in the outpatient arena. And of course, the problem is these are IV therapies of extremely limited supply. You could bring in expense, but the federal government has really bought the whole first 1 million doses of this and is just pushing it out. And so I'm happy to say that in San Diego, we're actually trying to work on getting this more available to outpatients in underserved communities, and healthcare partners as well as family health centers will be piloting the administration of these agents to only the highest risk patients in the coming weeks. Okay, so on to the bulk of what I want to talk about is the impact of HIV on COVID-19 or SARS-CoV-2 infection. And here's another polling question just to keep you awake and see what people think. HIV affects COVID-19 susceptibility in the following ways. A, people with HIV are more severely affected due to immunocompromise. B, people with HIV do not have severe consequences of COVID-19 due to lack of cytokine storm. C, antiretrovirals are effective at inhibiting both HIV and SARS-CoV-2 replication. Or D, people with HIV tend to have more comorbidities and are therefore more severely affected by COVID-19. And I'd like you to choose just one, if you could, in the chat for this one. And again, apologies that I couldn't get it up to a formal polling question. We have a very highly educated audience here, and pretty much everybody is weighing in with D. So very good, and nice to see everybody's name there. So yeah, I think the answer here really is D. All these other things were actually theories or thoughts at the beginning. And it's interesting, I'll detail a little bit about how, and I hope I don't offend anybody with this, but HIV exceptionalism has really persisted through the years, such that in terms of vaccine availability, HIV is almost automatically on the list of a condition that purports or that conveys increased risk, although I think I'll go through the evidence. There's really kind of limited evidence for that. And I'm interested in their discussion and thoughts about that. So the conventional wisdom here is that severe immunodeficiency portends a higher attack rate and complications for most infectious diseases. We know this from the experience of taking care of our patients with HIV and AIDS, especially as their T cell counts fall, below 350 or so. But there's experience from prior coronaviruses, SARS, CoV-1, and MERS, that really, despite immunodeficiency, there was only mild to moderate disease seen in HIV patients. There's one particular report that I have referenced there on the bottom there that there's really no SARS disease seen in 19 people with HIV that were hospitalized together with SARS CoV-1 patients in a common clinical team where they really should have been susceptible to attack in that situation. And what we've seen in early publications that I'll summarize in the next 10 or 15 slides or so is that people with HIV and low CD4 cell counts actually had comparable outcomes to patients without HIV. Although I will say there's much more data on people that are doing well with well-controlled HIV than there is on those with low CD4 cell counts. And please, I don't intend this to be an exhaustive search because I haven't had time to do it, but in the literature that I've seen, really not that much of a risk. And then there's of course the intriguing possibility that antiretrovirals may have some anti-SARS-CoV-2 effect, and I'll address that a little bit as well. In terms of other immunodeficiencies, patients on TNF-alpha inhibitors and other immunomodulatory drugs for rheumatologic or dermatologic or GI conditions really have not seen any association with severe disease. In fact, there have been some reports in case series of rheumatologists saying, I'm not really sure what's going on here, but my patients are not really getting that sick. And it's kind of interesting to postulate why that is. Some of these drugs are being studied, such as tocilizumab or baricitinib, as being useful in that secondary inflammatory phase of the illness, and maybe that's what's going on here. However, it's really a different story in other forms of immunodeficiency. So solid organ transplant and hematologic malignancy, there's definitely some reports out there of increased mortality and increased susceptibility. And I would say probably not enough data to make a firm conclusion, but one of the sort of splashy reports of reinfection that resulted in death was a woman in, I think it was the Netherlands with Waldenstrom's macroglobulinemia, who was getting an anti-B cell agent, presumably rituximab or something like that, and she actually died, I think, 8 days after an infusion. So you definitely need certain components of your immune system. But the role of T cell immunity is it's really not exactly clear. It's complicated, as we know. Those of us that take care of HIV, the T cells do a lot of different things. I would encourage you to review a paper that was put out by the La Jolla Institute of Immunology by Shane Crotty's group. I think the author is Dan et al. That really analyzes and I know a lot of you actually participated in this study, recruiting almost 200 people to really fully characterize the immune response to SARS-CoV-2. And it's complicated, but CD4 cells certainly do appear to have a prominent role there, but it's just not really been clear whether it's necessary to protect from severe disease. All right, so I'm going to go through sort of temporally and then sort of in order of quality of evidence what we have. This is one of the initial reports that appeared in CID, really a population-based cohort between January and April of patients in Wuhan. And they basically, a lot of these initial studies were sort of case control studies or just cohort studies looking at large populations. This was 6,000 people in a cohort of people with HIV, of which only 35 developed COVID-19. Of course, a totally different epidemiologic situation there with the severe lockdowns. But 15 of those had severe illness. Again, were they testing enough? Is the right denominator? Not really sure. But what they did is they compared the incidence, case severity, and case fatality of COVID-19 to the general population. And there really wasn't much difference here, except they looked at shedding of SARS-CoV-2, I think using PCR in this particular study, looking at a median of 30 days. So some enticing information that maybe people with HIV shed longer. They did say that people that were viremic with HIV had sort of what looked like a weaker immune response, so lower levels of IgM and IgG than those who had their HIV well controlled and who were undetectable. And then kind of an incidental finding of this cohort study was that 3% of their patients had a total disruption in their antiretroviral therapy, which honestly I think is not that bad. 3% out of the whole cohort missing their medicines. And so the authors comment that really maintaining the supply of ART is critical, and that maybe there's a little bit of increased shedding in people with HIV, but not really a difference in terms of severity of disease. I put this study up here just for the residents and fellows in the crowd, just to use your critical eye in terms of the quality of evidence. This is the kind of thing, just as an example, no hard feelings for the authors here, but this is the type of report that was showing up in the literature early on, and it's almost entirely useless in terms of making conclusions about what's going on here. This is just a descriptive case of 5 cases that were in the hospital on ART. A couple required oxygen. They got azithromycin and a cephalosporin and hydroxychloroquine, and they all recovered. So not much conclusion that we can make about that, but just as an example of the quality of data that we had early on. So then we got to more substantial numbers here, and this was really coming out of New York City, most of these studies, because they had the brunt of the epidemic early on, as you'll all recall. And so this is 88 people with HIV from the group at Mount Sinai, I believe, hospitalized in March and April. And what they did is they matched the people with HIV by age, sex, race, ethnicity, and week of infection to controls in a 1 to 5 manner, and then did a comparison of clinical characteristics and outcomes, looking to see if there were any differences in these cohorts, and essentially concluded that there was no difference in the adverse outcomes of COVID-19 by HIV status in New York City. And I'll show you the data on the next slide here. So the patients with HIV are in the black bars, and then those who are uninfected, the controls were in the gray bars here. And with respect to all of these outcomes they looked at, whether it be death, ICU admission, mechanical ventilation, composite adverse outcome, which is sort of a grouping of all those, really no difference between these two groups. And you can see the Kaplan-Meier analysis over there on the right with really no difference in the curves. Interestingly, though, when you parse through the data a little bit more, there was definitely a higher proportion of smokers in the HIV cohort and a higher proportion of comorbid illness compared to the uninfected comparators who they tried to match by age and ethnicity and all these other things. There really was no difference by HIV status overall. And they did see, poor outcomes in people with HIV. I'm not denying that, but they were really similar to the comparator groups. As you can see, ventilation 18 versus 23%, and death about the same. And the cumulative risk of death over time was similar. So based on this, it doesn't really look like there's an increased risk in our HIV patients. Another study here, a little bit bigger, again, retrospective, large academic health system here, and looking again at the association between HIV and death, ICU admission, and intubation. This is 8,900 patients, of which 161 had HIV. So again, sort of a case control type design. And again, another finding which I think is interesting is that the people with HIV had a significantly higher prevalence of hypertension, diabetes, hyperlipidemia, and CKD, which in and of themselves, as I'll show you later, are known to be risk factors for severe disease. And you can see the p-values over here on the right-hand side, where there's really significant differences amongst those showing up in hospitals with HIV, that the HIV patients actually had more comorbid illness. So this, from a scientific perspective, makes it very difficult to parse out whether it's the HIV or whether it's all these comorbidities that we know so well are appearing in our HIV positive patients. Again, they didn't see any statistically significant difference in the ICU admission, intubation, or death. And this is the first row on this table here. So all comers, you don't see any significant relative risks here. Relative risk of 1, actually 1.01 in terms of ICU admission, 1.41, although with a wide confidence bar in terms of intubation, and 1.01 for death. However, there's another interesting finding here in the subgroup analysis, where those people who had HIV who were less than age 50 actually did have worse outcomes in terms of intubation and death. You can see the bolded relative risk there of almost threefold increased risk of intubation in the younger group, and then a 4.3-fold increased risk of death, although the numbers are quite small, in the younger group as well. And the conclusions here are that people with HIV included more males and those with more comorbidities, especially in the younger groups. So it's kind of a hard concept to get your mind around, but if you think about a cohort of people under age 50 who are coming into the hospital with COVID, those with HIV are actually much more likely to have those coexisting comorbidities, which may explain those unique findings in that group, even though they weren't prevalent overall. As to why the older cohorts at 51 to 65 and 66 and over didn't have any differences, maybe that's because the general population sort of catches up, and then the populations were more balanced in terms of the comorbidities. So here's another one coming from Emory, a lot of the same thing here. I just thought this was remarkable. I'll just go through this quite quickly. 530 people with COVID-19, only 20 of those that had HIV, but sort of down towards the bottom of the slide, you can see that half of the patients had more than 5 comorbidities, with almost all of them having hypertension, a lot having dyslipidemia, and half of them having diabetes. And so nearly all the people with HIV and COVID-19 had very well-controlled HIV in this COVID-19 cohort, and yet a high comorbidity burden with those numbers there as well. So probably not the HIV that's driving things here, but the comorbidities. So getting bigger, let's go to a sort of a multi-network study. I'd say higher quality of evidence. This is up to 50,000 patients, of which 404 had HIV infection. Again, picking out interesting demographics, possibly related to sort of social determinants of health here, rather than the actual HIV disease itself. Again, higher proportion of diabetes, obesity, kidney disease, and tobacco use. And interestingly, in an unmatched analysis, the people with HIV had a higher mortality with a relative risk of 1.55, higher inpatient admission rate of 1.83, but they did some propensity matching, and this mortality difference essentially disappeared. And so again, the conclusion, which hopefully you're seeing is now consistent over several studies here, that the crude COVID-19 mortality is higher. However, propensity matched analyses reveal no difference in outcomes, suggesting the mortality is driven by the comorbidities and not the HIV. All right, so then let's get to the sort of a bigger study, even going to higher quality of evidence. This is getting to a meta-analysis, systematic review and meta-analysis, looking at just basically which conditions are associated with COVID-19 mortality. And this kind of drives home some of the things that we've known from the literature. And I picked this out because it actually includes HIV as one of the factors that they look for here. More studies looking at cardiovascular disease, 14 altogether in this meta-analysis, 13 hypertension, 16 diabetes, and it's much more limited in terms of HIV. I think there were 3 cases there as well. But let me just show you the data to see what falls out in terms of statistical significance as an association with death in patients with COVID-19. So on the left forest plot here, this is cardiovascular disease. You can see the summary estimate here in sort of that purple color, clearly statistically significant with an odds ratio, it looks like above 2. Hypertension also significantly associated in this meta-analysis with an odds ratio, relative risk of 1.82. Cerebral vascular disease, not quite statistically significant, although a trend. Diabetes, also just barely statistically significant. We've seen many other studies that really support diabetes as a real risk factor for mortality. COPD didn't show up in this meta-analysis as being significant. Kidney disease did, as you can see there. Chronic liver disease, not quite. I think it's probably a question of definition of what is chronic liver disease, because people with sort of chronic viral hepatitis without cirrhosis may be different than those with cirrhosis. And then congestive heart failure you see as well is significant in this meta-analysis. Cancer, just barely. Asthma, not really. And then HIV, look at that. The summary of only three studies here is actually right at 1. So really no significant increased risk for mortality. Here's just a summary table that they used as well. So the increase really looks like it's cardiovascular disease, hypertension, diabetes, congestive heart failure, just barely, kidney disease, and then just barely cancer, with the strongest associations being for kidney disease and cardiovascular disease. Keep this in mind when we start talking about vaccine distribution for those with comorbid conditions and whether HIV belongs on this list or not. And what didn't fall out here is HIV, liver disease, COPD, cerebrovascular disease, and asthma, not significantly associated in this particular meta-analysis. So there's one exception to most of what I've shown you so far, and this comes from outside the US. So this is a study similarly done in using publicly available data in Western Cape and South Africa. And this kind of stands alone as really one of the pieces of evidence that refutes everything that I just said. And we can postulate about the reasons of why that is. But this was a population-based cohort of over 3 million people in public clinics in the Western Cape. 16% of the patients were HIV positive. And then in this cohort, 22,000 people had COVID-19 and there were 625 deaths. And the associations that were strongest with death were male gender, increasing age, obviously diabetes, hypertension, and chronic kidney disease. But also, as you can see in the bottom of this forest plot with respect to TB and HIV, actually there was a significant finding here where HIV patients had a 2.14 hazard ratio of increased mortality. I don't have the detailed analysis of the CD4 cell counts in these particular patients, and then TB or current TB with a 2.7 hazard ratio as well. So really this study sort of stands alone as one of the only ones that does show that HIV and tuberculosis as being independently associated with increased COVID-19 mortality. And I think it's going to be up to us to interpret this. You know, do we wait for more data? Do we just take some caution here? Of course, we always want more data to help make our decisions. And then one additional study just showing, this was presented at the AIDS meeting. I actually couldn't get a hold of the abstract, unfortunately, but this is a screenshot from a clinical care options report. This just shows that people who died actually did have lower lymphocyte counts and final absolute lymphocyte counts versus those who recovered who had HIV. And I'm not sure we can make too much of this because there actually were no differences, as you see on the bottom, in age, sex, BMI, HIV duration, nadir, or presenting CD4 cell count or viral suppression. So I personally think this is just a finding that we see of people that are on the way towards death, that we have just really major perturbations of their lymphocyte count and of their other inflammatory markers. Okay, so I wanted this to be a really robust section about vaccines in people with HIV, but unfortunately we don't really have all that many pieces of information. Of course, there's 6 real major candidates, and the one that I didn't see, I know the Pfizer vaccine is being reviewed at the FDA Saturday after the advisory committee voted yesterday to approve on a 17-4 vote. I looked at one of the tables that was in the EUA document and did not, I think there was just a handful of HIV patients in here. So I'm curious to see what the EUA actually says with respect to people receiving this vaccine. It's not a live virus vaccine, so it'll be interesting to see what they say here. But you know, we'll be making decisions essentially based on no data in terms of the Pfizer vaccine. The Moderna vaccine, you may remember that there was some advocacy that took place and they actually resulted in an amendment to include patients with HIV in that trial. So we will actually have better data in terms of Moderna. And then I saw Dr. Little on the line here. I believe in AstraZeneca and Janssen that both of those trials did allow well-controlled HIV to be included. So hopefully we will have additional data there, and I'll see if Susan wants to chat and tell me I'm right or wrong. And then of course we have other vaccines coming. This gets very tricky when we're talking about EUA approved vaccines being available and still trying to conduct a clinical trial. And that was Nettie, not Susan. See if Susan can chime in there, or somebody from the co-VPN. I did want to report back to you in terms of what the local activity is for vaccine allocation in San Diego. So this is a clinical advisory committee that's been convened by the county. You can see a lot of county members there, and then sort of community members here. Dr. Sawyer, my mentor in medical school, actually is the UCSD representative, and then I think good representation from around the community to try to work through really these mandates and guidelines that are being pushed down to us from ACIP and from the state of California. And it's interesting, this type of work. Once you get sort of a nice plan, you realize that you have to dive into such a granular level to see actually where the vaccine is going to go. So you may know that the National Academy of Sciences started with this framework, which I thought was very well run by Bill Faggy and Helene Gale that co-chaired this, and really bringing in the ethical ideas of who gets a limited resource first. So this happened in September. It was a 5-hour, really well-conducted, open scientific discussion with full transparency. And it resulted in this sort of phased approach to vaccine, keeping in mind that there's going to be really limited vaccine in the very beginning, and we should give it to people that are most risk of dying or most risk of being infected. And that's exactly what we've sort of seen consistently. I'll show you the ACIP breakdown in just a little bit. But then what comes next is phase 2. And this actually, I think, in the red box that I've circled here, is where it becomes relevant to our HIV patients. So in phase 2, there's an indication to include frontline workers, and actually one of the revisions that happened between the first draft of this and the second version after the public comment is that schools were included in phase 2. I, in my own testimony to this group, made sure that essential workers were included here as well. That second bullet point there. And then we get to people of all ages with comorbid and underlying conditions that put them at moderately higher risk. So this is an interesting thing to think about based on all the evidence that I've presented so far. You might take that list and just say, well, the strongest evidence is based on the things that we saw in that meta-analysis and other similar meta-analyses, where it's cardiovascular disease, kidney disease, diabetes, obesity. And the question really is, should people with HIV be included in that as well? The ACIP looked at this, and just to make things confusing for all of us, essentially took, let me go back one slide, took the phase 1 and phase 2 developed by the National Academy of Sciences and sort of, crunched them together so that phase 1 and phase 2 are now the new phase 1, A, B, and C, and then phase 3 and 4 are now phase 2 and 3, if you follow what I'm saying. Essentially, phase 1 and 2 have now been combined. So we're now in phase 1A, presuming that the FDA does vote for authorization of the Pfizer vaccine on Saturday, and then I think we're headed there. There was really only very, very little discussion in the meeting yesterday, and it really centered around the margins, I would say, regarding age, the lower age limit between 16 versus 18. One of the abstentions, I heard an interview with this pediatrician that said, well, there's just not enough data in 16 and 17-year-olds. There was only 160 folks out of 40,000 in the trial. So 80 16 or 17-year-olds have received this vaccine, so not enough data. We'll see what the FDA says about this. Also some discussion about pregnancy, because pregnancy really wasn't included. And then the severe allergic reaction, I think, is something we all need to pay attention to. Of note, the Pfizer trial excluded people with a history of severe allergic reaction or anaphylaxis. So they reported that there were no serious anaphylaxis events in these 18,000 or so people that received the vaccine. But really, we need to study this further. And I think Paul Offit is the one that made the suggestion, like, why don't you do a study? Otherwise, this is going to be dogging us, especially from the anti-vax community, that anybody with any allergic rhinitis or who has an EpiPen for any reason is going to be really reluctant to take this vaccine. But anyway, suffice to say, we're in phase 1A, where healthcare personnel and long-term care facility residents are really the priority here. In phase 1A, I'll break down what this looks like in San Diego in just a bit. But then we have to quickly move to phase 1B, essential workers, and then phase 1C, adults with high-risk medical conditions. And this is where our patients with HIV would fall into place. Don't get me wrong, we have some time to think about this, because it's going to take really quite a while even to work through phase 1A, as I'll show you on the next slide. So basically, to get more granular, you have to zoom in on these populations. It's not enough just to say healthcare workers, because what does that mean? Does that mean emergency responders, paramedics, and EMTs? What about police officers? Are they considered healthcare workers? When you talk about acute care, psychiatric and correctional facilities, are you talking about just the doctors, nurses, and lab techs and respiratory therapists? What about the people mopping the floors and doing the food service and collecting the labs and the secretaries and that type of thing? So lots of discussions here about how to implement this, and it's really going to be, I think, difficult with our limited quantity of vaccine doses to sort of make it through here. But then, as you can see, tier 1 is just that first thing. I don't even fall into tier 1 as an outpatient doctor. That gets into tier 2 with sort of intermediate care, home health, community health workers, FQHCs, and clinics. And then tier 3 brings in other specialty clinics, outpatient clinics, lab workers, dental, oral health. So here's the list, but what does that actually mean in terms of numbers? I'm going to zoom in even further. And this, just to give you, this is just phase 1A, tier 1. And here we go. My estimate, adding all these up, is that in the hospitals, about 80,000 people, and this is not my estimate, this is the county's estimate. Amongst first responders, we have about another 5,000. Amongst dialysis centers, we just know the number of centers. They're working on enumerating how many people that is. But in my estimation, this is probably over 100,000 people. And I think Carl Steinberg mentioned that there's probably 10,000 nursing home residents as well. How many nursing home staff on top of that? So we're looking at over 100,000 people in phase 1A, tier 1 in San Diego. And our first shipment of vaccine is going to be 28,000. So that's kind of discouraging, but I think the encouraging thing is that we're expecting ongoing shipments of vaccine on a sort of bi-weekly basis. And then thank goodness that Moderna, well, I shouldn't say it's not approved yet, but the amount of doses that California is receiving of Moderna vaccine, I think the governor just tweeted a couple of days ago, is likely to be double that of the Pfizer, so 600,000 doses as well. Of course, we need more than just these two companies. We need more vaccines. And it would be nice to have a single dose vaccine or one that's more widely available coming down the pike as well. Now, I just want to finish with some of the language that's in the National Academy of Sciences specifically related to HIV patients. So I'll just read this here. They say, in addition to the CDC's list of comorbid conditions that put individuals at increased risk, CDC has also compiled a list of comorbid conditions that might put individuals at increased risk. And this includes asthma, cerebrovascular disease, cystic fibrosis, hypertension, immunocompromised state, immune deficiencies, as well as HIV. So there you go. There's sort of a solid list, I think, that CDC is going to say. Then there's sort of a moderate list here where the evidence is a little bit less certain, and we're going to have to work through whether HIV belongs on that top list. I'm interested in your opinions after hearing this talk. And again, one more statement that's later on in their guidance here, that people with the following conditions might be at increased risk for severe illness from COVID-19. And that's where immunocompromise falls in there, including HIV. All right, so I think, am I going in the wrong direction? Okay, so here we go. I just want to finish up just so people are aware of some other things. Of course, this is more of a practical issue about challenges in prevention and treatment. This is just showing, this is from the group at Brigham and Women's in Boston. And I'll just jump right to the conclusions here so we can have maybe some discussion. That almost all the people with HIV and COVID-19 in this particular cohort had a comorbidity associated with severe disease, highlighting the importance of non-HIV risk factors in this population. And also a link, this is a study, if you get into the depths of it, it really links social determinants of health to our HIV patients as another potential reason, in addition to the comorbidities that's related to severity of COVID-19 illness. Just a quick comment on co-occurring mental health and substance abuse disorders. We've seen this in our MAT clinic and in our HIV population as well, that distancing is really, really hard on people, especially with addiction, substance use disorders. People are having worse cravings, they're having drug supply that's interrupted, increased withdrawal and increased risk of overdose. I'm just now starting to see some publications of the overdose numbers, and they're awful in terms of how many people are dying, especially with fentanyl being involved in our supply. I can attest to this bullet. I mean, I personally am drinking more alcohol than I really regularly have to help with sleep and stress and that type of thing. There's been worsened anxiety and potential increase in intimate partner violence as well as domestic violence. The last thing is that tobacco. We don't think about this, but it's really impossible to observe social distancing and hygiene recommendations when you're smoking cigarettes. You know, it doesn't really work with a mask as well. So don't forget about that in terms of encouraging people to quit smoking. In terms of disrupting HIV prevention, This has been a tough one because we still want to stick to our guidelines and make sure that people get that negative HIV test if they're continuing on PrEP. There's been sort of variable interpretations of sexual activity during the pandemic. Some people are continuing to be quite active, and some people are not. But really, globally, many prevention services have been paused or scaled down. I can tell you that our community outreach and testing efforts almost came to a complete standstill in terms of our community-based HIV testing, which is really quite concerning because that's really our linkage to care pathway. And just finally, to show you that there are some guidelines. I'm just mentioning these. I don't want to poo-poo them too much, but it's really just some common sense type things in terms of looking at these comorbidities, like I've shown you in the data. Limited data really does not show a more severe course of COVID-19, but of course, caution is warranted while we wait for more data. Really important emphasis in these guidelines from DHHS and other places that maintaining the supply of ART is really important through telehealth or through increased refills. Of course, ensure that the general health maintenance is as usual with influenza and pneumococcal vaccines. And then, of course, the advice is the same, really, regarding social distancing guidelines. A couple other recommendations from DHHS here about thinking about a 90-day supply, maybe going to mail order. Delaying regimen switches, this is kind of interesting. There was some initial thoughts that protease inhibitors such as lopinavir, darunavir, and potentially even tenofovir might have some antiviral effect for SARS-CoV-2, but the recommendation is pretty strongly that we shouldn't be changing regimens because the evidence here is pretty weak. In fact, I remember seeing actually a press release from Janssen, who makes darunavir, saying, please don't switch to our product because the evidence is really not solid enough. This has been interesting for me in terms of routine monitoring. I think there's been really an allowance for people to make a risk-benefit calculation of whether you need those labs in somebody who's been suppressed for 2 years or so. Routine care should be postponed to the extent possible. These guidelines came down really early on in the March, April, spring surge, but I think they're very much applicable now as well. And then also the same, really nothing new, nothing different from people with HIV in terms of guidelines for evaluation, management, and considerations for admission. Just a couple of words here on lopinavir, ritonavir. We do have some data here, and the IDSA has actually weighed in and said, it's really not that great. There was a New England Journal publication showing that this really did not have effect in vivo, although it may have in vitro. And then also, here's another thing on lopinavir, ritonavir about the evidence there. CDC's guidance on HIV and COVID-19 is pretty bland, I would say. Not really anything. There is a statement here about can HIV medicine be used to treat COVID-19, and they say there's no evidence really that medicines for HIV are active against SARS-CoV-2. Finally, there's some AA-HIVM guidelines out there that are also very practical, just to say, basically all the same stuff in terms of giving a good supply to your patients, whether it be ART or MAT, such as buprenorphine and other things. Even with pain medications, try to use electronic prescribing or telephone visits. Cancel routine follow-up office visits if you're in a state of crisis. Keep waiting rooms as empty as possible, and sort of do all of the usual infection control that you need to do to keep your patients safe. So I think I'm going to stop there and hopefully have some time for discussion in the final 10 minutes. I thank you for the invitation, Daniel and Marvin.
Yep. Well, thanks, Christian, for that excellent overview. That was quite a lot of topics there, and there were a few comments from the chat pod, and I think you've probably seen many of them, but I'll kind of try to go in order just to make sure we cover it. I think Nettie initially started with a few comments about, first one about telemedicine being a bright spot and hopefully will be helpful in the future, even if not in the pandemic, which I'm sure you will agree with. She'd also said that she'd seen some patients die from non-COVID events, but wondering about association with stress, depression, not accessing care. So maybe I'll see what your comments are regarding that.
The question about mental health interfering with
yeah. She's just wondering about stress, depression, not accessing care, perhaps, and people dying from non-COVID related events.
We had 3 people die, or I think 4 deaths, and we don't have that many deaths in our practice. And we had a kind of a cluster of deaths that were not COVID related, but 2 cancers and heart disease, something else. And it was a it was surprising to me. It made me wonder if they were sort of a sign of the general poor health that we're seeing, sort of COVID adjacent, or as a secondary effect of not accessing care, or depression or stress or family disruption, medicine disruption, all of that.
Yeah, I can comment on that. In addition to the profound effects of isolation and mental health, I think people are just legitimately avoiding care. I mean, there's some good literature from Northern Italy when they had their really severe lockdown, that they looked at out of hospital cardiac arrest, and they just essentially skyrocketed because people were having heart attacks and not really calling EMS. So I think that's certainly something, but then you factor in missed immunizations in children, you factor in missed cancer screenings. It's almost like everybody's presenting later in their course of disease. And so that's certainly, and then I would add on to that addiction and overdose, the sort of diseases of deaths of despair. There hasn't been a lot reported on this, but there's some limited data suggesting overdoses are really, really increasing quite a bit.
Yeah, and I think Nettie also commented. I don't know if she wants to comment there, but had a statement about I think HIV might be a risk factor in that our patients are more likely to be in health disparity communities and increased risk of exposure. So she seems like she's fine with leaving them on the higher risk list, even though medically there may not be any significant difference.
Yeah, Nettie, do you have a comment on that?
Well, I think you touched on it, Christian. I mean, I think it's sort of like we are an HIV community here. So, we want to advocate for our patients, and it feels like they face so many challenges that I'm fine letting HIV be in the higher risk group, even though the data doesn't necessarily support it that we have. But I think that we know that our patients, I think it would be acceptable to sort of let that one slide and not say, no, the data doesn't support that they are higher risk, because they tend to be in health disparity communities and have so many other challenges that it's really hard to tease it out. So I guess I was just kind of saying that, I agree. When I tell the individual patients, I say, I don't think you have any special HIV related risk, but at the same time, in my mind, I know that as a population, they face the challenges that are facing other communities that are hardest hit by COVID. So I feel sort of like it's acceptable for them to keep that spot on the list as a higher risk group.
Yeah, Nettie, Nettie and I get to debate this in the regional vaccine clinical advisory committee. One of the things I mentioned, Nettie, is that we're going to have to take some very practical decisions based on equity. And there's, I will just report to you that on our first discussion, there wasn't much talk about equity and how to include equity in the distribution. And I sort of agree with you, Nettie, that would be one way to infuse equity in terms of how we allocate the vaccine. The second, which I think is very important, is just geography. From the South Bay, just look at the maps. In my opinion, that really should be guiding us in terms of where the vaccine is distributed. And if you remember, I didn't emphasize it on this talk, but the National Academy of Sciences has that maroon colored stripe on the bottom, which really recommends equity as a cross-cutting consideration, and a recommendation to use something like the CDC Social Vulnerability Index or something like the Healthy Places Index, which are really these composite tools that really attempt to give you social determinants of health. Look at the map in San Diego. It's the I-5 corridor down to the border, and it's El Cajon. And that almost overlaps completely. The Social Vulnerability Index or the Healthy Places Index overlaps completely with our COVID map. So I'm looking forward to really pushing our county officials to include that in terms of how the vaccine is rolled out. And then, Nettie, it's a good point that including HIV is another way to help combat disparity.
All right. Looks like I think Jill may have a comment. I'm going to just go through a few quick things, and then I'll call on her in a second. So just making sure we don't miss anything. Susan Little did respond to you, Christian, that yes, HIV participants with well-controlled infection are allowed on both the AstraZeneca and Janssen study. Francesca says here that she felt that everyone in a tier should be included, not only the direct care providers. And then she updated that they expect a second shipment of the Pfizer vaccine on the week of the 21st, and then the first shipment of Moderna, about 2 million doses for California, also arriving on the 21st. So Jill, did you have a comment?
Christian, this was such a great talk, really so comprehensive and very informative. I noticed something earlier on in the epidemic, and I'm not sure how it's going to play out, but with a lot of resources shifted, people like retention coordinators were not doing that work because they sort of had to be shifted to other places. And I noticed that a few of my patients who normally come in weren't. And then it turned out that they had died of other things. And this was just, this is an anecdote, but I wonder when we look at this, that we're going to find their patients that are just missing, that we haven't seen in a while, our most vulnerable, our hardest hit by that. And that something, happened to them. And we're going to learn this. It sounds like we're starting to learn, but I think we still haven't seen the total extent of this, right? Because we have some patients who don't come for a year. They're the ones who come back and forth, and they just may not return. And that's, I had it happen with 2 patients, and it was really jarring. And I think we're going to just see more of this. And I'm curious what the experience has been at family health centers and in general.
Yeah, absolutely in line with you. But the interesting thing is that telemedicine has actually allowed us to find some of these people. So they might have just disappeared, and you scratch your head and say, I wonder what happened to that person. Then you move on with your 20 patients you have to see. Now they're showing up on the schedule, and I'm reaching people that show up and they're in Mexicali, or they're in Moreno Valley, or they went to stay with a relative or something. And to me, it's the economic devastation that's driving these people away. People are newly homeless, newly unemployed, really just surviving, and they do what they can to sort of go, where they need to go. We would just chalk that up to, you're just lost to follow-up or falling out of care. But it actually is a direct or indirect related to the pandemic. That's what we're seeing.
So I see Francesca pulled up her camera. So did you have a comment to make?
Yeah, I wanted to say to Christian that yes, the way of addressing, or the way we've addressed at UCSD these zip code disparities and this population is really to take an area entirely, right? We have a lot of our healthcare workers who live in Mexico, and who live in South Bay. And so we want to cover them, right? It's not so much the risk at the hospital. It's what we're seeing is there's a lot of community spread in the community. And so if we cover an area in some ways as a community, right, that area then will also translate by vaccinating all of the people in that work area. We will also cover geographic areas.
Yeah.
So that I think is very important.
Yeah, I couldn't agree more. I think I got the feeling from the advisory committee that we are mostly on the same page with this, that it's not just the healthcare providers, but really everybody in the building that should be vaccinated in the very beginning. I have heard of some reports that are doing exactly the opposite in different states, where they're taking the idea that, for example, prison guards should be vaccinated, but prisoners should not. And that's just exactly the wrong thing to do, in my opinion.
Yeah. So a few more comments. So Jeff Taylor was asking about are providers seeing increased PTSD in their long-term HIV survivor patients? And I think there were people in the chat who said yes. I don't know if you have a quick comment about that.
Yeah, I forget what the source was, but I saw a paper looking at those mentioning mental health issues versus those seeking care for mental health issues, and it was a huge difference. So it was more than 50% saying that they had experienced anxiety, depression, PTSD, and something like 5 to 10% had actually sought care. So there's a lot of additional work to be done. Our mental health department has gone right away with telemedicine and telehealth and really tried to expand that way. So I would continue to encourage people to seek out mental health care.
Yep. And I'll also echo mental health for us as clinicians and healthcare workers. I put in a plug in the chat for our Keeley Medicine webinar on January 9th. So if people are interested. Carla Torres wrote a comment here about HIV testing as part of a COVID workup.
So, there's been a lot of people that want to want to jump on all this COVID testing and you know, do Hep C testing and HIV testing as well. I don't know. I have sort of mixed feelings. Look, when I'm at the tents, I'm asked to see 25 people in 4 hours, and it's really laser focused on symptoms and COVID and really getting them safe from that perspective. And it would be nice, you know, if you put an HIV hat on to just blanket the whole community and test everybody. But the practicalities, I think, actually take precedent here, and it's not likely to happen very easily in our setting, at least.
We can, however, build on the outreach infrastructure that's been built around COVID. So that's one way to utilize, you know, to take all this that we've invested in COVID as far as testing infrastructure, but outreach infrastructure. We have COVID kits that get delivered to people's houses. You know, all that outreach infrastructure, I think, is a great opportunity to layer on top other health disparity conditions in our outreach, right? So TB, hepatitis, et cetera, that you could do the outreach for those. HIV, you could do your outreach as part of that networking that you've already built for COVID. So I hope we're not going to build all this and then just like be done with COVID and walk away, but have all this infrastructure in these health disparity communities and then stay there and go ahead and work on all of the other conditions. I was in TB meetings all week this week, you know, and that's really important that we take this opportunity.
Yeah, and we are cautiously restarting our community-based HIV and Hep C testing, especially down at our syringe exchange. Just now that we're sort of flush with PPE, we can do this, but you know, we're worried about our staff also getting infected as well. So
Yeah. Well, it's the 9 o'clock hour. I think I was just going to probably try to end it here. I know there were quite a few other questions, but I think we're a little bit running out on time. So I wanted to finally thank Christian Ramers again for giving the last talk of 2020 on COVID, the year of COVID. And we will start again next year. I think our first session is going to be on January 8th, and that will be given by Mr. Patrick Anderson, and it will be focused on language and HIV. So language matters in terms of what language we use, and the topic will be about that. So I wanted to wish everyone a happy holiday season. We thank you for your participation throughout the entire year. Wear masks, stay safe, and hopefully we will see you all in the new year. So thank you all very much.